Dr. Timothy Olweny is the Secretary General of the Kenya Association of Private Hospitals. He also runs a facility in Nakuru called the Evans Sunshine Medical Center. Dr. Olweny, karibu sana to the Situation Room.
Is it sunshine or sunrise?
Sunrise.
Yes.
Sunrise.
Yes.
Karibu sana to the Situation
Thank
Room.
you.
It's good to have you right there. We have the hot seat right there. And we will be discussing a matter that is covered in all the dailies today. It's in the news. Let's look at the story in the Standard, page 12. Private hospitals threaten to stop treating NHIF card holders. The tiff stems from owners of private hospitals lamenting that money remitted by the National Hospital Insurance Fund, NHIF, is too little to offer quality care in private hospitals. According to Dr. Olweny, who's here with us, this stalemate to change is attributable to stalemate to changes under the new NHIF contract with private hospitals. It comes into effect from the 1st of February, next Tuesday. So you said, Dr. Olweny, come Monday, unfortunately, we might not provide services because contracts that have expired will not have been renewed. And then you're saying that these new contracts that have come into effect, that have been offered by NHIF, have deviated from the previous contracts that you've had in terms of what the payment for various services is going to be. So let's just, first of all, understand the background of this, the gist of this whole thing. You have present contracts that have expired, and the new contract should come into effect from Tuesday.
Yes.
When was this new contract entered into? This current contract?
Thank you. Just to provide clarity on this issue, the NHIF usually contracts healthcare providers in a 3-year cycle. And the reason NHIF needs to do this is because NHIF is an insurer and promises its members healthcare services, but it doesn't have the capacity to deliver them because that's not its core mandate. So it has to contract healthcare providers to do the same, to deliver on their promise. The last contracts which we had were running for the period 2018 to 2021. And the NHIF's financial year is similar to the government's financial year, so the previous contract expired at the end of June 2021.
Mm-hmm.
What has been the practice in the past? And it makes sense if you're going to be what NHIF refers to itself as a strategic purchaser of health services. You cannot promise to deliver without negotiating with the suppliers of the healthcare. So what has happened in the past is if there are any material changes to any contracts that are proposed, we'd have a discussion and iron out whatever issues there might be so that come the time when contracts are going to be renewed, there are no issues on the table to be addressed. This last time, this has not happened. So in 2021, the contracts expired. It necessitated an extension of a few months and a subsequent one for a few months. And the last time now, it was in December, and they were extended for a further 1 month. We have consistently asked the management on NHIF to provide us with the drafts of these contracts, to provide us with, so that we can peruse them and see what the contents of the contracts are going to be. The message we got at the beginning was that they could not provide us with that information until the board approved the contracts. Then our question was, once the board approves the contracts, are they approving a draft? Then they come back to us. Then again, they go back to them for ratification. And we're told, yes, we'll get back to you. That didn't happen. They held these contracts close to their chests. They went to the board. Apparently, they were approved. And the next thing we had was our providers being sent contracts individually and at random. Because, for example, in my facility, we've not received a contract to date. But you're being told, come and sign a contract within 24 hours. You're either in or out. Some people were being even summoned to bring their lawyers to hotels to sign contracts, a 100-page contract which you've not perused. So we said this is not right. On 22nd of December, we wrote to the CEO. This was our association, together with the professional associations, Kenya Medical Association, Kenya Dental Association, and another association which represents primarily rural hospitals called RUFA. We said, as far as we're concerned, we have not seen this contract. So our advice to our members is we cannot sign those contracts until we peruse them. We give you our position, we negotiate as we've done in the past. That again didn't happen. So come the 31st, we had an extension for 1 month. No stakeholder participation and engagement has occurred that is meaningful. We've been invited for Zoom meetings where we've got slide presentations where they talk about many policy issues in terms of what the packages involve, but there is no substantive issues, there is no pricing, and so on attached. When we asked to be sent these presentations, we say, as usual, they have not been ratified by the board. So finally, we got a meeting, the first meeting, which was on Zoom, which is not our choice, because I don't think it's an effective means to be able to engage on a wide range of issues like what was on the table. We were told that within 2 days, we should present what our position is on the legal issues. In terms of the pricing, we said we needed more time, because when you talk about, for example, procedures, all the medical procedures under the sun, you cannot discuss that a line-by-line item, and each of them discuss their costing and pricing within a few days.
Yeah.
So I maintain that much as we are talking to you on this, there is not sufficient time for us to effectively engage on this issue. Subsequent to that, we had a meeting where we presented our concerns about the various legal issues. They were supposed to get back to us. At the meeting, they said, and this is expected, they said, there's too much content here, we can't respond in this forum. We'll get back to you. We were supposed to have a meeting a few days later regarding the pricing. It kept being postponed, and now we're back to, again, giving providers contracts and telling them take it or leave it. So that is where we are.
Okay. Dr. Olweny, what are we looking at now? What are we looking at as the core issue of this supposed standoff, right? Are we saying, as you have told us now, that the issue is new contracts have been crafted or drafted,
Yes.
but you are not aware of the contents of the contracts? Or are we saying that, as maybe by guess, that you are being asked, as has been reported in different platforms, that there is an issue of costing, which private hospitals are saying they're not going to be able to do? For example, 3 sessions of dialysis for a certain amount of money, and there used to be 2 previously. So what's the issue here? Core issue. Contracts have been drafted, we are not privy to the information, or we're being asked to offer services at the same price that we're offering for them in the last tranche of time.
Now, in response to your question, there's a myriad of issues. Firstly, I would like to clarify what has appeared in various sections of the media, both mainstream and alternative. This is not necessarily a payment dispute. Some people have made it look and said that NHIF, we've got an issue with previous claims and so on. This is not a payment dispute. That I'd like to clarify. Secondly, we're not denying anybody service come Monday. We're just not going to be able to see them because we've not been contracted to provide the service. There's a huge difference. If we had a contract and people are coming in and denying them service, that is denial of service. Here, NHIF has actually not yet contracted us. And a contract, we can't be forced to enter a contract which is detrimental to our well-being as organizations. So that contract, there's no discussion that has been had. Thirdly, there are various clauses which are just unpalatable for us. Firstly, we have got, they have changed the categorization of hospitals. In the past, we had various categories, whether they were public hospitals and private hospitals, and some which would over what they referred to as comprehensive services. Comprehensive services meaning that you provided the entire range of services you're contracted to provide, but without any additional fees being levied to the beneficiary. And then you had other private hospitals where we were allowed to co-charge for various services. So now they've said, we want to simplify this. We want to have only 2 categories, comprehensive and non-comprehensive. However, even under the comprehensive contract, when you look at this, what the contract they have titled as comprehensive, they have again sequestered a set of services and said, you are non-comprehensive. In other words, you're allowed to co-charge. But for these services, you're not allowed to co-charge. And they've said for surgical services, for radiology, surgical, radiology, and I think there's a third category which I forget. And dialysis. And dialysis. You're not allowed to co-charge, meaning you must provide that service at the fee we have quoted on the contract. If you ask for any payment from the patient, you're in contravention of the contract.
Yes.
Then becomes the issue of the dialysis you're saying. They were paying 9,500, which already was a concessionary rate, which private hospitals, for example, agreed to provide service based on the issue that we were going to get volumes. So economies of scale were going to be in operation. Then they've lowered the price to 6,500, which doesn't even meet the absolute cost of the materials, leave alone the professional service or the infrastructure. It doesn't meet that cost. Then they are saying you cannot charge any additional amount. That doesn't make sense. So at the end of the day, what's going to happen is you opt in or you opt out. If we opt out, what happens? And I must emphasize here, our primary concern is for the patients who are accessing these services. If you have a patient who is not going to be able to get dialysis for a week or two, because much as I had somebody from the Ministry of Health talking yesterday on TV and saying that 90% of the services are offered in public hospitals anyway. So by implication, he's saying private hospitals don't matter. First of all, that is factually incorrect. Private hospitals offer up to 50% of the healthcare services in this country. So for you to say that dialysis patients overnight are going to be able to move and transition from private hospitals to the public sector and get that service is unrealistic because they don't have the capacity.
Dr. Olweny, can I ask from a point of view now of access to healthcare?
Yes.
And especially for those who aren't able to afford the 8,500.
9,000.
Oh, the 9,500. If you look at it from an access to healthcare point of view, the government, there can be an argument that, number one, have private hospitals been overcharging? There have been cases of overinflation, exorbitant charges on medical procedures. We've seen stories coming out in the newspaper of this. So could this be an attempt to rein that in? Second is who is able, if government is pegging it at 6,500, there must be, are public hospitals able to offer dialysis at that rate? And how come they're able to offer at that rate? And what can private hospitals do to offer at that rate? I think the third point is, could government be trying to move out of private hospitals? Might they be trying to move into supporting the public sector to come up? Because we can see, for instance, a lot of patients going to India because healthcare provision is just too expensive. So what about access? Where is the citizen in this? Is there an overcharging happening? And is there a lesson also for the private sector? Of course, stakeholder participation should be there. Of course, the benefits package should be well negotiated. It should be standardized. But again, if NHIF is paying for very expensive services, it means that there are lots of Kenyans who then aren't able to get the services. So what would you say?
To those?
Yeah.
I know there's always, whenever we mention the word private hospitals, there's always the issue of charging, and this is a question that comes up perennially, the issue of charges. First of all, I must say at the outset that we are not a homogeneous group of institutions. Just like with hotels and restaurants, we've got different levels. And basically...
Just like with public hospitals.
Yes.
There are different levels.
Yes.
Schools.
Yes.
Different levels.
And that is why even we have been categorized in terms of levels all the way to 1 up to 6. So first of all, you're not a homogeneous group. In terms of the infrastructure, and I'm talking about infrastructure broadly, meaning physical infrastructure, human resource infrastructure, and so on, we're also not the same. So the pricing cannot be uniform. Let us accept that. It can't be uniform. You cannot have one hospital where somebody has invested 10 million shillings or 50 million shillings charging the same as another one where somebody has invested $1 billion. And people plug into whatever level they want to plug into, and that's how private institutions work. So once we have agreed that there cannot be no uniform charge, then the issue of overcharging becomes almost will not apply.
So
But there
there's
can be
overcharging?
standardized charging.
Or can government then say that we will pay up to this much? So these
Yes.
others are for those people who can pay.
We're on the
So
same
that access can...
Exactly. And that's what the issue of comprehensive versus non-comprehensive is supposed to be. First of all, we must agree that the National Health Insurance Fund is a members' fund. It doesn't belong to government.
Yep.
Members are the ones who have got a say in terms of where they access services and what benefits they get.
Through this
NHIF's
board.
role should be to determine that we will be able to provide you these benefits up to this extent. If you want to go to a hospital that charges more than that, then you will have to top it up. Now that's why we have an issue with the contracts. How do you say that you are dictating to us that we cannot charge anything more than what you're able to
Isn't
pay?
this a decision of the board of NHIF? I'm assuming.
But I'm
Yes.
also looking at it as the greater public good. When a patient is unwell and they require dialysis, it doesn't matter their financial status. They're not in a good place. And dialysis, like I said earlier, is not a one-off. It's not, you got a headache, so we just give you a painkiller and hopefully within it works very fast. You'll be done. So, isn't it? And that's why they're saying there are several services: dialysis. What else were the others?
Surgical
Surgical,
services.
yes. So where
And
they're
radiology
looking
services.
in if we look at how much we paid in the last year, to private and public hospitals, this shows that there's a huge chunk of people who are actually seeking these services, both in private and in public. And it's because of the lack of enough facilities and public that people also end up in private seeking the same. It's the same argument that you also used to accept the charge of 9,500 because you looked at, well, there's a huge captive market. There are very many people. We're going to actually have the economies of scale and numbers. So isn't it the same argument, Dr. that you can use and say, okay, now doctors, specialists have said 3 dialysis sessions a week is the optimal. NHIF is saying, okay, we agree, but can you offer the same service at this 19,000 shillings?
But that has to be subject to negotiation. It cannot be one of those take it or leave it arrangements. And that's where they're going wrong. They need to sit down with us and tell us our rationale for coming up with this figure was this. We tell them this is what we are incurring in terms of this cost. So even for you to meet costs, we have to meet at some point, isn't it? The challenge we have here is these arbitrary unilateral decisions cannot work in this healthcare system because we are not subject to the control of NHIF directly. One thing that people must remember in this country is that private hospitals insist because there is a need for them, isn't it? We don't just exist because we wake up and say, let us. We are providing a service, and
Yes.
that's what people forget.
That's true.
Secondly, you must remember we provide massive amounts of employment in this country. The government, first of all, is not even able to absorb the number of healthcare workers who are being churned out by our institutions. We provide employment. We pay taxes, isn't it?
Yep.
So let us not look at private investors. And for us to be able to encourage investment in this space, there has to be policy stability. And this is one of the biggest problems I have.
How would the
Policy stability, what
previous negotiations working? Because that's one thing that you say is fundamental to this entire thing here. That you're not necessarily having an issue with whatever the case may be, but can we sit at the table and see then how we can work it out? So this would be the only year in the last 4, 5 that they have not called you to the table and said, okay, this is what is actually going into the contract. Number one, why do you think that they haven't called you to sit at the table? And number two, how would you go about it previously? Is it, look, this is what I have to offer, or we can't do that. Can we shave off a shilling here or there? How would it previously run?
Previously, just like in most other contracts where people deliver service, close to the expiry of the contract, we have a sitting. We say, we've almost come to the end of this cycle. Let us have a sit. What has the experience been? These are the changes we're proposing. What do you guys think? We want to adjust this pricing in this manner. Will this work for you? That's the kind of discussion we always have, and we have it prior to expiry of the contract. I don't want to speculate as to why we've not been called to have meetings this time, but I'll state 2 facts. One is that NHIF Act has just been gazetted yesterday. All right?
Yep.
The thrust of that act is to, first of all, broaden the base of subscribers. So the number of people, it has actually become mandatory now that people must have NHIF.
Yes.
So already contributions have gone up by basis of that alone.
Yes.
All right? So we're getting more money. That is a fact.
And members have increased.
Yes.
Members have increased.
Not all
That means-
contributing at the highest level, though.
Yep.
Yes. Not all contribute at the highest level, but regardless of how you look
There's
at
a
it.
contribution.
So it could be conceivable that this action is to broaden the base, bring more people onto the fund, and to do that, then the services, the packages, have to be at a more affordable cost.
Sorry, just repeat what you said.
Yes, by government seeking to get more subscribers onto NHIF, more beneficiaries, it means that you're bringing a lot of people who are not benefiting from NHIF are the poor, who aren't on NHIF because they can't even afford the subscription. There's a lot of Kenyans, by the way, who don't even seek medical intervention because they can't afford. And so NHIF really is to try and ensure access to health for everybody. Now, what it means is they want to maintain quality at a price that can be afforded. So could this be an issue of trying to get the price right so that more people can come on board? And the discussion, stakeholder engagement is critical, should have been there. It's a constitutional principle. But the principle also of getting more people onto the NHIF, getting the service more affordable is important because health services are driving people into poverty.
That is
Health in Kenya is bankrupting people. People pay
Very
more than their annual income in healthcare. It's not, I mean, a country can't grow in the state we are in.
Just tell us, what are the details of this contract that you have, great concern with?
Firstly, I talked about earlier the aspect of nomenclature of categorization of hospitals into comprehensive and non-comprehensive.
Yeah.
It is all over the place. It goes back and forth saying non-comprehensive people can provide comprehensive service for this and sequester others and say you can't provide comprehensive service for the other. Then there's the issue of the fees that are proposed. And I'll give an example for the surgical rates.
Yeah.
And I think for our viewers, it's important that we know that it's not that private hospitals are trying to be greedy. We cannot promise you something we can't deliver. And I'll give an example. Simple surgery for removal of an appendix. It's called appendectomy. First of all, we must know that the medical board, Kenya Medical Practitioners and Dentists Council, has got guidelines which it sets for professional charges. And the recommended charges is a range. And as per the 2016 guidelines, doctors are supposed to charge between 60 and 120,000 for that procedure. All right? It's a range between 60 and 120,000, depending on the level of facility again, and level of doctor, and so on. Then, if every surgery needs an anesthesiologist as well. They traditionally or customarily charge 1/3 of the surgeon's fees. That is not to say it is fixed. There's some where the anesthetic risk is higher and so on. But let's say, for argument, it's 1/3. So that's 20,000. Let's work with the minimums only.
Okay.
So 60,000 plus 20, 80,000 for doctors' charges. All right? Then after that, the hospital should charge their fees. The proposed fee in the new contracts for everything is 40,000 by NHIF. In other words, it is half of what the doctors should charge before we add on the hospital charge. Is it feasible for us to deliver service at this rate? And then tell us that we cannot co-charge.
How much was it before?
Before in the previous contracts,
yes.
depending on the level of institution, they were providing the service for up to 80,000, 100,000. And again, it was varied with different facilities. So before they had a fee structure that was dependent on the type of institution. Now they've said they want to harmonize it. So they want to offer 40,000 to everyone.
Was there any institution that was charging less than 80,000? That was that NHIF could pay less than 80,000?
No.
Maybe the faith-based supported.
You see, that's what I'm saying. These charges, even for the public
Faith-based.
health sector and faith-based institutions, when we had an initial meeting, when we were engaging NHIF, faith-based institutions, under the umbrella of CHAC, which is Christian Health Associations of Kenya, and KCC, which is the Kenya Conference of Catholic Bishops, also had serious concerns about this. And that is why we were all engaging NHIF. But NHIF pulled the plug on discussions. I don't know for what reason. So that's why I'm saying the contracts as they are, it's a no-brainer. It's not one of those where we're considering, should we sign them, should we not? They need to explain to us where they're coming from with this. And that's why I'm saying NHIF is full of brilliant people. And I get very disturbed when brilliant people do not so brilliant things.
Could there be political considerations, number one? And is there, in terms of instructions, is there scope for extending the contracts to iron this out? Because from where I sit, government obviously has a policy objective to get more people onto the NHIF. This means the cost has to come down. And obviously, possibly the way it's being done is then not taking the interest of the private health providers. And government can't deliver any health services, the universal healthcare, without the private providers. So this conversation needs to happen. But is there a case, Dr. Olweny, for these rates to come down? And regionally, and maybe across countries at our level of development. Countries or at our level of development. How are these rates? Are our rates competitive? Are they high? Are they low? Because from where Kenyans stand, we find healthcare
It's expensive.
exceedingly expensive.
Bottom line.
And it seems to be, the board, the medical board, is doctors, is healthcare professionals, and they can set this rate. So where is the interest? And I keep coming back.
Is there a case for them
interest
to be low?
for the citizens?
Doctor.
Is there opportunity? Last point, government underspends on healthcare. And there's a gap. They're supposed to be at 15% of the budget going on health, it's only 8%. So what are the disconnects? Because the person suffering here is the citizen.
Indulge me if you may. Let me explain, first of all, start with a broader discussion about universal health coverage, because that is the word that everybody is banding around, and that's what we aspire to be. Universal health coverage has got 3 components. There's access to healthcare. Second component, which people don't talk about, is the quality of care you deliver must be of sufficient quality to be effective. And thirdly, you've got what we call financial risk protection. So what you're discussing now, it should not expose the user to financial harm. All right? Those are 3 components of UHC. Access, and historically, what happens is any country that decides, let's provide universal health coverage, you always start and you concentrate on access. And that we did pretty well in terms of expanding the coverage. Remember, NHIF before used to pay for bed only. In fact, it used to be called Kulipia Kitanda, isn't it?
Yep.
So we expanded that in terms of the package of benefits that they were providing. They expanded that scope. All right? So they started with increasing access and then said, now we're providing outpatient cover, dialysis, and so on. So these were all good things which Kenyans have enjoyed for the last few years. Then comes a challenge. Always what happens is the cost goes up. And I'm not talking about cost per unit, I'm talking about overall cost, because now you're providing healthcare to a large number of people who in the past didn't even have access to any of this care. So what happens is knee-jerk reaction is people say, how do we control this cost? All right? In 3 dimensions, you've got what we refer to as the breadth of universal healthcare. Breadth meaning the proportion of the population that's covered. So policy-wise, in terms of government, you always want to increase that, all right?
Yep.
Then there's what we call the depth, all right? Then, in other words, now you want to increase what benefits are you offering, the range of services. Then the height is the proportion of the costs. That determines the volume of public health expenditure. Now, what's happening is we've got limited amount of public health expenditure. So artificially, what we're trying to do, we don't want to reduce the package of services we're offering. We don't want to reduce the number of people who are covered. But this cost, we want to bring it down artificially. It can't work. So the way to approach this is this. When you talk about financial risk protection, outpatient care rarely impoverishes people. Rarely makes people poor.
Yep.
Because even for the rest of us, it's very easy for you to say, you've got somebody who needs an outpatient consultation, you'll send your relative by M-Pesa 1,000, 2,000 shillings, get seen even in the periphery, and they will have gotten the care. What impoverishes people is inpatient care, surgery, dialysis, chronic illness.
Sessions.
Can we just concentrate on what we can afford and provide it effectively, as opposed to promising people an entire package of services which are not going to be deliverable? So you asked the question earlier, there might be a move to be able to say we want to move all the services to the public sector. State it. Just state it. As opposed to trying to tell private hospitals that offer services at rates that are not sustainable, that are impossible, state it. But one thing I can tell you, with 50% of the services being offered in the private sector, if you move all the services to the public sector, forget about UHC.
But is there a case to lower
Yes,
the costs?
and we already have in the past. Let me tell you, even the previous rates that have been in operation for the last 3 years have been concessionary rates. And the reason for that was we make marginal profits, but because of the volumes that NHIF was delivering, people were able to stay in business.
Okay.
Especially for those people in rural areas. And that's why I'm saying that the rural private hospitals are in a dire state because their business model is dependent on NHIF.
Yes.
People don't have the ability to pay. So what we are saying is, if they cannot be able to provide the service that they have in the past, they're shutting down. And these are people who are providing service to medically underserved populations. So you'll have people who not
Can
able
I
to
ask a
access any
direct
service.
question, Dr. Ari?
Yes.
Is it not possible to provide the 3 dialysis sessions for 19,000 shillings?
It's not possible.
Why? What's
In
the
government
cost?
service, it can, let me tell you, because they get funded by the exchequer. In public facilities, it can possibly.
It's
They get funded by the exchequer, they get their supplies from KEMSA, and so on. So, first of all, the unit cost for all the supplies is much lower. They don't have an expenditure on payroll. They don't have expenditure on other infrastructure. Private hospitals don't. So, it's not possible.
How much does it cost you per unit for one dialysis session?
Depending on the institutions that you talk to, and that's why Kenya Renal Association have done a lot of work on this. And I think the figure that came up was had to be a minimum of 8,000. But that's why I'm saying we need to sit at the table and talk. This thing of shoving figures down people's throats and saying take it or leave it, it's not going to work.
Taking all factors into consideration. Okay, so come Tuesday, with the state of things as they are, with the current status quo, what happens on Tuesday? Because you know how many people are visiting a facility on a given day, and I think this lends to now what Wanjiro is saying here, what happens then on Tuesday? Things remaining as they are currently. What happens on Tuesday for people who are showing up to hospital with their card and are not able to access services?
Earthquake number 2.
No, we don't want to go that direction with
Anyway.
human lives.
Actually,
That's said on a
human
light
lives.
note.
But
What I'm
we-
saying
but
is
we-
Extend
this.
the
we're
contract.
headed there.
No, it's,
What I'm
Demand
saying
an
is this.
extension of the
it's a
contract.
reality of it. I mean, let's not even cost it. I mean, because if somebody comes to your facility and they have NHIF and they're not able to pay directly, you'll basically tell them, sorry, I can't offer you the service. Is that not what you're saying?
I am hopeful reason will prevail and the contracts will be extended like they have been extended for the last 7 months. That's what I'm
Wow, it's
hoping.
7 months.
We've been extending them since July.
So extend them further to allow for
And
conversation.
engage us
to go on.
actively so that we can hammer out an agreement on how to be able to provide service.
Is this what
that we have
happens
done.
with the other insurance providers?
Yes, exactly.
Pick Aeon, Minet, Jubilee.
Exactly.
Do they come to all the facilities and say, come, because now we have X number of members who have taken up this insurance policy, so let's have a conversation?
First of all,
Do they talk per association or per facility?
The private insurance industry actually has harmonized a lot of the contracts that they have through AKI. So they basically have a standard contract. And the contract, in effect, says it sets rules in terms of how we're going to engage, but in terms of the pricing, that is negotiated per facility. And in fact, they usually offer it based on the prevailing prices at that facility. They can come. And based on volumes, for example, they can also sit down and say, you know what, we need concessions on this and this and this. You reach an agreement at that level. But it has to be something that is feasible. So discussions do happen even with the private health sector. And that's what we're encouraging with NHIF because they're in the same predicament. They promise people healthcare services. They don't have the capacity to deliver it. So you have to negotiate with your suppliers of healthcare, which is the providers.
You know, the thing that I find interesting is that the bottleneck seem to have been perhaps NHIF not having enough resources to meet the needs that are required by their members. But with the discussion and the realization of more members coming in, that cannot be presented as a problem. Now, when you say you are able to, well, you're willing to have these discussions, the question will be, what is the minimum that you are going to be willing to accept when you negotiate?
When I was being taught negotiations in business school, there's a strategy called anchoring, where somebody comes and proposes something that is absolutely ridiculous, and then wants you to use that as a basis for discussion. So that somebody tells you, now I've given you 20% on where we started. We are going to start on the previous rates that have been in operation up to today. Then we make modifications based on that. We are able to understand what the financial predicament of NHIF is. And that's what, if they have, they should let us know. But my feeling is, let them tell us this is what we're able to offer. Let those who choose to get services from private facilities, and those especially who go on a non-comprehensive program, give members the option of being able to top up. Because you must remember, there's also a constitutional issue here. And there's also a third, an issue to do with NHIF membership. You cannot be an NHIF member, and then NHIF decides to dictate which facility you should go to. They should offer you a certain range of benefits and give you the choice to choose what facility you access those services in. And there's also another issue which is also controversial in the contracts, where there's the issue of multiple insurance. They have put in an obligation of healthcare providers now to determine whether somebody else has got other insurance or not. So, for example, if Eric comes to hospital and I've got a contract, I ask you, do you have any private insurance cover?
Yep.
And if you say you're covered by Jubilee Insurance, I say, NHIF now say they are not going to pay your bill until you exhaust your Jubilee Insurance cover, which is a principle in insurance which doesn't even make sense. It might be one of those things that is not law, but it is a guideline, it is general practice that both insurance companies should pay to the extent of their liability in proportion to the benefits that you're supposed to have. But now they're saying is, because I have additional insurance cover, I'm going to be discriminated against. NHIF will not cover my bills other than rebate, which means they're going back again to the issue of bed until my cover is exhausted.
And yet, you're a fully paid up member.
Yes, and the truth of the matter is the people who have got additional insurance are also the highest contributors to NHIF. So there's also a constitutional issue there, which I think can be subject to some serious challenge. So there are a lot of concerns that we have with this contract, which we need to sit down and iron out. Because again, as a healthcare provider, if now you lie to me and say you don't have it, then they discovered another later date that you had Jubilee insurance, my claim is not being paid. It's not my responsibility. So chances are we'll go there, and the other insurance companies also have the same requirement. They say they pay their bills net of NHIF. So when I come, I'll be saying both people are not paying first. So who is paying?
Yeah,
What did they
that's
do
where
in
the
India?
issue is, because currently the first charge is going to what? NHIF,
Yes.
and then my private cover comes in.
Yes.
Surely, my private cover, I can see the sense for the other way around. Because yes, I contribute to NHIF. If I'm able to afford the extra private insurance, then my NHIF contribution is also helping others. Okay? And if you first of all exhaust or get to a certain percentage, let's say 40% of my private, and then NHIF kicks in, it makes sense to me. You may have issues of, constitutional, the right and all, but it makes sense because there's a greater good. There's a reason why I pay more than a very high premium for the private, and I'm not paying such a high premium for the NHIF.
Yeah, I agree with you, but there's two factors here. There's a factor of accountability, because I think the principle that those who are able pay more, that's a fair principle. But of course, access to health should be for all. But there's an issue of accountability. So if employed, whatever, are contributing more, is there accountability in the way that money is used? And then the other aspect is, back to the point I was making, that according to the Maputo Protocol, to grow and sustain health services, you need to contribute up to 15% of the budget into the health sector. Kenya is at 8%, and you don't even factor the corruption there. So this deficit, the gap we are talking about, is around accountability. I think, Dr. Olweny, you also haven't told us about the costing comparative in the region. How did India manage to bring down those rates so that Kenyans would rather use their local insurance to go to India? Because healthcare is accessible here. So these rates are not affordable. On the other hand, private providers need to be remunerated fairly. So I think there's deficits of accountability. Goes back to, I don't want to use that language of criminal enterprises.
What you're raising is a cost of healthcare debate, and that's also a very wide debate. One thing we must appreciate, that healthcare is a very complicated product, which has got a wide range of inputs. And much as a lot of the people in the private sector are told that you're overcharging, the truth of the matter is we don't determine the cost of those inputs. One of the reasons why Indian cost of care in India is so much lower is because of medical supplies and cost of drugs. Do we determine the cost of drugs? No, we don't. They're sold to us at this cost, and we are going to sell them at this cost. It's that simple. So when you go to India and the cost of drugs is going to be a third of what we are paying here, that is a wider issue. Healthcare provider compensation. You are aware about the industrial unrest we've had in the health sector.
Yep.
It's not us who determine the costs of the fees that are paid, the salaries that are paid to healthcare providers, isn't it? We have to work with the people that we have. And this has escalated in the last many years, isn't it? So a lot of these things that we talk about, the cost of healthcare, cost of inputs, are also within the preserve of the government. And this goes back to the point I keep saying, we have the right to healthcare enshrined in our constitution. Is it an absolute right? Is it even achievable? And whose responsibility? Who is the addressee of those health rights claims? It is the state. And secondly, the individual. One, directly, because you also impact on how healthy you can be by your health behaviors, but secondly, by your democratic right to vote. You determine that. So even the population has got a role to play, but that right to health cannot fall on private healthcare providers.
But
it is the role of the state, and that's why the state taxes people, isn't it?
The state in partnership with, the moment private sector enters into a partnership for service delivery, it's also bound by those responsibilities.
Yes, but is this a partnership? Like what we are discussing now, the engagement, is this a partnership?
And actually,
this is an abusive marriage.
Actually, it's interesting because what you've done is you've shown there's the unions, there's the health unions, there's that part, there's the government, there's the patients, the citizens,
and there's
NHIF. And then there's a private providers and NHIF, these stakeholders.
As Dr. Olweny has mentioned, is full of brilliant people, okay? NHIF simply used to pay for your bed once upon a time, okay? Then they upped their game. Now, they didn't up their game without going into the where-to-fores of how best this can be managed. So once they got into this, they may have come across certain headwinds that they hadn't foreseen before. It's understandable. But nonetheless, what I'm hearing is this: what I'm hearing, an organization that is trying to save money, an organization that has issues that they can't bring to the fore, but yet they're grappling with, and they're trying to transfer these very same issues to other people whom they know they partner with. In short, they are at a position where they are not admitting to the insufficiencies that they actually have as an organization. Because out of the blues, you've had this relationship. Why suddenly bring about things which even you would understand would scuttle the relationships that you actually have with these people? Because everything that I'm hearing points to that. And it seems deliberate. Why?
Because one, NHIF has a new CEO. Is it CEO? Came in last year, immediately also started talking about some of these things. So that is why I was saying there's a political agenda in that government has a policy objective. But even in implementing or taking forward its policy objectives, there has to be stakeholder consultation. And I agree, NHIF has brilliant people. There are also brilliant people advising the NHIF and the government. But are they listening? We talked about CBC the other day here. Good project. Implementation approach botched. So that is why I'm saying accountability deficits, because there's a lot of money coming in. How is that money being applied? But also this political, kind of agenda of we need to score a point, we need to be seen to do this. You have to move with the stakeholders.
I think, just like the doctor said, there is breadth, depth,
And height.
and height. NHIF only deals with the height because it's about purchasing the service. The breadth and depth is the state and county government, national and county governments. And the conversation they are not having, they are not engaging on, okay, so how do we make sure that there are more health facilities that are closer to the people? How do we make sure that people don't have to travel far? How do we make sure that people know about their primary health and they're taken care of at that level? If we don't have those conversations at the same time, we'll always be left to have the conversation of the height, of the cost. And the cost will be the government facilities will not be talking. It's the private healthcare providers who will be talking, but we are not going to move. And just like you said, UHC is about those three. So it's important that you raise the issues that you're raising. Then we also focus the attention on who needs to be responding and who needs to be acting. What do they need to do? The Afia Mafia House needs to tell us what they are doing with the documents that they have on UHC on expanding access to healthcare. Why must people be going to 50% of the services being offered by private? Is because government is not public. Public is not doing, public is not meeting. And if public and private are not, if government is not working with private to expand even the facilities that they have, to make sure that they're getting, for example, concessions, so that Dr. Olweny can open up satellite facilities in conjunction with the government, we're not talking. Am I saying?
Yes, I'd mentioned the aspect earlier, in fact, about policy stability. And you have to have an environment where investors are comfortable that you're going to have this policy today and it's going to be in place for a reasonable amount of time for them to be able to make any meaningful investments. I've given the example about, for example, you're in a peripheral area, in a far-flung area of this country where there are underserved populations. There's a need for healthcare. They could not pay for it. And now because of the NHIF, the social health insurer being able to pay for it, you invest and say, now I'm able to provide this. Then all of a sudden, the rates that you're being paid drop to 50% overnight.
Yeah.